So when I became a student nurse midwife, we get to take some electives, and I was interested in this. And so I tried to learn more about it, and within the curriculum there was nothing. So one thing I was able to do is become a sexual assault nurse examiner, which was good. That sort of gave me a group of people who understood trauma. But that was more about what was happening now and acute stress disorder. And so in order to learn what I was thinking I was picking up on, which was more the long-term after effects of trauma, I ended up connecting with psychotherapists and to nurses who were psychotherapists as well. And they taught me a lot about rape trauma syndrome and also about what happens when the woman doesn't recover in the immediate aftermath of rape. And that's when I started learning about PTSD. And this was in like 1994, 95, which was right when the DSM-IV came out, where PTSD, the definition of it was no longer that it happened in the aftermath of trauma that was outside the range of usual human experience. That was the old definition. In 1994, the definition was changed, and it became very clear that PTSD actually happens in the aftermath of things that happen a lot, like child maltreatment or intimate partner violence. So the research in the field really began to pick up. When I was looking at it with my nurse midwife eye, what was I seeing? I was seeing a history of somatic conditions in the women and a history of somatic distress during pregnancy. Sometimes they were on antidepressants. Sometimes during internal exams especially, or other intrusive medical procedures, it seemed to me that they had quite intense distress that was not related to pain. So it was a very strong stress response. Also that they often avoided procedures or skipped appointments. They're often no-shows, but then you'd get a telephone call. Often they had a history of psychotherapy, and they were clear about their needs, so they were able to talk about their trauma history and what they needed from their midwife. But often there were still challenges in the provider-client relationship, like a lot of boundary testing and long time to build trust. Also, I noticed that very often they had low social support or partners that made me quite uncomfortable when they were present during visits. And often, if you asked them how they were looking forward to parenting, they could disclose that they had some concerns. And they would say things like, I don't have any good role models for this. I don't have anyone to help me with this. Occasionally, there were cases with quite extreme manifestations. And this had to do with the fact that at our midwifery practice in Toledo, we were the midwives for the Toledo Public Schools early adolescent pregnancy program. So we had in our caseload about 10% girls who were age 11 to 14. And they were shared cases with art therapists, psychotherapists, teachers, social workers, and the midwives all together. And so they often had post-traumatic stress reactions that I learned a lot from because they were quite extreme. And I was able then to talk with therapists and social workers and really build a knowledge base from clinical experience that was very, very helpful there. So I think that now, that I've gone to the other side and I do research, this is what the phenomena looks like to me. So it's actually a little clearer. But basically, this is the framework that shapes our program of research, where violence trauma leads to PTSD, which manifests as neuroendocrine alterations. And I actually study cortisol and oxytocin in particular. Also to behavioral alterations, so substance use and intimate partner violence, but also highly dysregulated eating and are involved there. And now I would put a third pathway bubble in there, which is the genetics, because we are coming to understand that there are probably some genetic variants that are involved also. And that these things can lead to adverse outcomes of childbearing, but it's not a very straightforward process because these women also come in with medical and obstetric risks, and they also have a lot of concurrent life event stressors. So family of origin difficulties, often coping skills that are very adapted to trauma but don't always work well in real life and don't work well during pregnancy. And also there is a social gradient of trauma anyone in any layer of society is at risk for being maltreated in childhood or being maltreated as an adult woman. But the options for recovery are much greater for affluent people. And so what we found in our large study that I'm going to tell you about is that women in low socioeconomic status are not any more likely to ever get PTSD in the first place. The risk for ever having it is the same, but the likelihood of still having it when you're pregnant is much greater for low SES women because they've not had opportunities to recover. The other thing that we're finding is that there are healthcare factors that can also influence things. So access to care, certainly, but also the level of alliance that women are able to have with a healthcare provider, and also the things we're learning about prenatal care is that our system of prenatal care is probably not optimal for dealing with this at all because prenatal care doesn't actually look like it's protective for women survivors of childhood maltreatment in particular. So I'll show you a little bit more about that.